I have a question for who anybody can answer. One part of patients of heart failure usually are having some sort of a CKD. Either they have a mild dry spleen, or some of them are in frank failure. So, and we find it very difficult. There are some trials which show you should use it despite the creatinine being high or the EGFR being low. So how does one approach amongst these experts who have told us today? How do they approach these problems and the hyperkalemia that can occur because of these drugs?
Right. So if I'm allowed to speak, like if you reanalyze or meta-analyze the SGLT2 data, if you have SGLT2 on board, now we know that chance of hyperkalemia is the least. If you have MRA on the board, the chance of hyperkalemia is on the extreme. Now, if you have MRA plus ARNI or ACE inhibitor, again, these are the highest group of people having hyperkalemia. So once hyperkalemia means ever hyperkalemia, the category of drugs can reduce the incidence of hyperkalemia. The problem of hyperkalemia is the inhibitions of prescribing MRA or ARNI again, because the kind of mental block that they may die, they may come to the hospital, and there may be medical legal issues. So I would say that drug plus diet is very important. The hyperkalemia incidence is very low with SGLT2, very low with beta blockers, very low with vericiguat. So once you have hyperkalemia, diet, drug, and a new drug of MRA class, that is finerenone, the chance of hyperkalemia is also very low.
Yes, much less.
There's some evidence that this newer potassium antagonist like petiromar or this sodium, whatever that is, I can't pronounce that also, silicate, sodium zirconium.
Sodium zirconate.
Zirconate, yeah. So there is some data on that you can use them along with this, because so that you can be more lenient in using the good drugs that you want to use or something. But I don't think there is.
Yes, sir, there is not much of data, but it increases a horizon to use. We can use in such drugs because we will be still then the chances of hyperkalemia persist, and we will have to monitor very frequently. Each patient has to be considered separately, because at the same time those patients will be having higher creatinine value and other things. Dr. Hajra told, like it is safe to start SGLT2 inhibitor and beta blocker. These are the two agents which are safe, and particularly as you told, we can in newer this is finerenone or newer molecule that we can use, and this potassium lowering agent. Still then this is an area where we'll have to be very cautious by using medications.
Yeah, thank you, Dr. Dayasagar Rao and Dr. G. Kane. Thank you for that. And I thank you all the speakers. Dr. Wanda has already left. Dr. Wanda, Dr. Sandeep Bansal, Dr. Satya Rautray, Dr. Prakash Agra. All of you have done a magnificent job in doing the presentation.